Pediatric Radiography by Brandy Jones. Continued introduction, age of understanding and cooperation, pre-exam introduction, and child and parent evaluation. Children vary. However, by 2 to 3 years old, most children can be talked through a diagnostic procedure without immobilization or parental aid. Introduction. It's important to introduce yourself and explain the procedure. Be simple and communicate in a language that they can understand. Also, communicate with the parent. Parent involvement. 3 options. 1. Observer in the room. Parent is in the room as an observer, lending support and comfort with his or her presence. 2. Participant is in procedure. Parent activity participates and assists. 3. Non-participant out of room. Parent is asked to remain outside the x-ray room. Sometimes children may be more cooperative without the parent in the room. Assessment of the parent is important and requires you to be objective. Immobilization. Generally, parents would prefer to help with immobilization of their own child. The parent must not be pregnant and properly shielded. Communicate with the parent. Proper mobilization and assisting tend to increase the quality of the images and would reduce the chance of a repeat, therefore reducing exposure to the child. Other forms of immobilization that could be used are tape, sheets, towels, a radiolucent sponge, compression bands, ACE bandages, or just some to name a few. Peds should always be adjusted with a short exposure time to reduce the possible patient motion. Seen here are several immobilization devices. A is a picostat, B is a imaging immobilizer for digital, and then you have your tandem board, and then other positioning aids. Wrapping with a sheet or towels is called mummifying. We will be doing this as one of your skills lab. Bone development. These are some fun facts I found and I just thought I would share with you. These are not for your test. Fun fact, kneecaps start out as cartilage, unconnected from the rest of your skeleton. Patella start out as soft tissue and ossify into the hard, strong bones we all know by age 3. So if you x-ray a 1-year-old, they will have no patella. Fun fact, you're born with about 300 bones and end up with 206. Many bones, like those in your skull, will fuse together as you grow. Bone development. An epiphyseal plate found until the skeletal growth is complete to full maturity normally occurs at the approximate age of 25 years old. Epiphysis of the knee. At 3 years old, it is not visible yet, but look at 12 years old, it is evident. See the arrows. Child abuse radiographic indications. A classic metaphyseal lesion, CML, rib fractures, and healing fractures. Classic metaphyseal lesion, specific fractures have high indications for child abuse, and CML is one. CML is a fracture along the metaphysis that results in tearing or avulsion of the metaphysis. Other names for this are more commonly known as a corner fracture or a bucket handle fracture, as seen here. It will appear as a crescent-shaped osseous density adjacent to the avulsion fragment. See the arrows. CML is caused by forces exerted on a metaphysis. For an example, pulling of an extremity from holding a child around the thorax and shaking violently, as seen in a shaken baby syndrome. Rib fractures, especially multiple and posterior, are strong indicators of child abuse, seen in shaken baby syndrome when hands are held under the axilla and shaken. Force is exerted in the anterior and posterior direction is enough force to fracture multiple ribs. Squeezing the thorax can cause costovertebral as well as scapula and spinosus fractures posteriorly, and the sternum anteriorly are all indicators of child abuse. Healing fractures in multiple stages of healing can also raise a suspicion for child abuse. However, a thorough history is important because multiple fractures could reveal osteogenesis imperfecta found in children as well. Child abuse, radiographic imaging skeletal survey. You would do an AP skull, a lateral skull to include the lateral cervical spine, an AP chest, a lateral chest, a right and left oblique thorax to include ribs, an AP abdomen to include pelvis, a lateral lumbar spine, an AP humeri, an AP forearm, PA hands, AP femurs, an AP lower legs, and AP feet. These images should have close collimation and proper technique. Do not put through modeled images due to poor technique. The better the image, the better chance the radiologist has to read it properly. Each cone down image is important. Do not perform a babygram and use excellent positioning. Different departments have different protocols. Make sure you follow your department protocol. Alternative imaging modalities. CT. Advantages including visualization of visceral damage, especially with abdomen, skull, and skeletal fractures. Diagnose brain injuries from shaken baby syndrome. MRI, assessing soft tissue and central nervous system damage. MRI is not generally the test of choice due to the length of time a child must hold still for. Ultrasound, imaging visceral damage such as a hemorrhage and a certain skeletal damage, plus is no radiation needed for these images. Nuclear medicine is useful for healing bone, visualizes bone in multiple healing stages. This is often used in conjunction with a skeletal survey when multiple fractures are found. Radiation protection and image gently. Image gently is a campaign to raise awareness of increased pediatric dose rate. In radiography, this means protocols such as number 1, eliminating the use of a grid for parts less than 10 centimeters. 2, collimation of the part size. 3, increase the KVP to decrease the MAS exposure. 4, being consciously aware of the relationship of the patient thickness, technique, and exposure value lead to reduction of dose for more radiosensitive pediatric patients. Minimize exposure dose. Proper mobilization, short exposure times to reduce motion and blur. No grid unless the body part measures more than 10 centimeters. See proper technique charts in your department. Gonad protection. Children's gonads should always be shielded, sometimes with abdomen and a pelvis. Images, you may not be able to use a shield. It may obscure essential anatomy. For those insistent parents that move or want the shield in the way, explain other safeguards that are made, like low-dose techniques, collimation, and the amount of exposures that will help relieve parent fears. Parental protection. If parent is needed in the room, make sure a lead apron is warm. Keep hands out of the primary beam when holding the child. When in the primary beam, lead gloves should be used. Females of childbearing age should be asked about pregnancy. Pre-exam prep. Have the room ready. Any necessary immobilization have out, shielding paraphernalia in place to put on. X-ray tube moved into place and lined up to the IR. The IR with a marker and technique already set up. Digital imaging considerations. 1. Collimation. Four-sided collimation for optimal quality. 2. Accurately centering. CR is more accurate to the center IR because the way the plate reader scans the exposed plate. 3. Exposure factors. ALERA. Lowest exposure factors to obtain quality image. Higher KVP, shorter time to reduce motion and blur. 4. Post-processing evaluation of exposure indicator. Check for acceptable exposure. If acceptable exposure is in range allotted for equipment. 5. Grid use. Grid, no grid, unless over 10 centimeters. Pediatric indications. You can find these in your Bontraggers on page 623. A pediatric chest, aspiration, asthma, croup, cystic fibrosis, epiglottis, hyaline membrane disease, and meconium aspiration syndrome. Pediatric skeletal system. These can be found on page 624 in your Bontraggers. Craniostenosis, development of dysplasia of the hip, idiopathic juvenile osteoporosis, osteochondroplasia, osteochondrosis, osteogenesis imperfecta, infantile osteomalacia, Salter-Harris fractures, spina bifida, and club foot. Salter-Harris classification, only used for pediatric fractures that involve the growth plate. Pediatric abdomen. These can be found on page 626 in your Bontraggers. Atresia, hematuria, Hirschsprung's disease, intestinal obstruction, necrotizing enterocolitis, polycystic kidney disease, polynephritis, hypertrophic pyloric stenosis, tumors, urinary tract infection, and vesicoureteral reflux. Abdomen, dorsal to cube, 40-inch SID, IR determined by the patient size, a non-grid unless it measures more than 10 centimeters, shortest exposure time possible, shield radiosensitive tissues outside the region of interest gonads. Patient it should be supine, laying on a radiolucent sponge, ensure no rotation, immobilized if needed. Your central ray should be a horizontal beam centered at mid-coronal plane, and for infants 1 inch above the umbilicus, toddlers and up 1 to 2 inches above the umbilicus. Breathing instructions. For infants, watch respirations when the abdomen is still exposed. If crying, expose as the patient takes a breath to let out a cry. For toddlers and up, hold their breath. For the dorsal to cube, ensure that the diaphragm has been demonstrated. No rotation, no motion has occurred. Optimal exposure factors have been used. Pediatric fluoro studies. A barium swallow, an upper GI, a small bowel, and a barium enema. Upper GI prep. Patient preparation. Complete patient history, an early morning schedule, empty stomach. Infants younger than 3 months, MPO 3 hours prior to the procedure. 3 months to 5 years, MPO 4 hours prior to the procedure. And children 5 years and older, MPO 6 hours prior to the procedure. An upper GI room prep. The table is horizontal, the sheet on the table, feeding bottle and or nipple, feeding catheter and or syringe may be needed, suction and oxygen, and immobilization devices. Upper GI study. Newborns to 1 year, usually 2 to 4 ounces of barium. 1 to 3 is 4 to 6 ounces. 3 to 10 years old, 6 to 12 ounces. And over 10 is 12 to 16 ounces. Upper GI fluoro positioning sequence. Supine, left lateral, LPO, RAO, right lateral, and prone. Small bowel follow through. 20 to 30-minute intervals, depending on the radiologist. PA or AP projections, depending on the radiologist. And once it reaches the ileocecal region in an hour, on average, it's considered finished. Post-procedure instructions. For example, they may need to drink more water than usual to try to flush the barium through. They may notice that the feces would be white. Equipment single contrast BE. Lubricating jelly, hyperallergenic tape, gloves, washcloths and towels, neonates and infants. You might need a 10 French silicone catheter and a 60 milliliter syringe. Single contrast BE. For children over 1 year of age, use a disposable enema bag, a pediatric flexible enema tip. Do not use latex or an inflatable balloon enema tips. A air contrast enema kit with a double line tip. Clear explanation to the parents and patient about what's going to happen. Before the exam should start, an AP supine KUB should be taken and shown to the radiologist. The radiologist will come in and perform fluoroscopic films, and he may ask or she may ask for you to perform overhead projections, possibly a supine or a prone image of the abdomen, as well as right and left lateral to cubes with double contrast, possibly a post-evac film, and then post-procedure instructions, warning the parents and the child that they may have white poop. Drink plenty of fluids. Post-reduction of intussusception after air or barium enema. An AP supine abdomen taken to demonstrate that the intussusception has been reduced. An image on the right demonstrates this by presence of air in the ileum. Genitourinary system, voiding, and cystourethrogram. VCUG and IVU prep. A VCUG patient prep, no special patient prep is needed. An IVU prep, no solid food for 4 hours prior to the exam. Encourage drinking of clear liquids. Prior to an IVU, a ultrasound scan of the kidneys may be performed. Urinary tract infections are very common in children, and this study may be used to check and evaluate vesicoureteral reflux, which is a common cause of a UTI, demonstrated during a voiding phase in the pictures to the right. Room and patient prep for VCUG. The table's in horizontal position. The fluoroscopic tower is ready to fluoro. Your contrast media is ready and on the IV stand. Explanation of the procedure has already been performed, and you are covering the patient with for patient privacy. Procedure for the VCUG. Void prior to the procedure if at all possible. A catheter will then be inserted. The bladder is slowly filled by gravity. Fluoroscopic images are taken when the bladder is filling and is full, and then during the voiding phase. Post-procedure imaging may be requested, optional per the radiologist. The end.